Hi, good evening, everybody. A warm welcome on this Wednesday evening. After much hype and talk and requests, today we've got a fantastic topic and something which is very, very important for us. We'll be speaking about the role of home nebulization in obstructive airway diseases. At the onset, I'd like to thank the Indian Chest Society for bringing this series of webinars. Dr. Amita Nene, Madam, who's the Secretary of the Indian Chess Society, and Dr. Rakesh Chawla, sir, for the President of the ICS, for having a series of webinars to educate one and all and to disseminate knowledge in today's day and age. The role of home nebulization is often neglected and taken for granted. And we've got our eminent speaker, Dr. Neel Thakkar, a very dear friend, a fantastic speaker, a good orator from Vadodara, Gujarat. Neel is a DTCD, DNB, EDRM, IDCCM from Hinduja, EMPH and FICS. He's a consultant pulmonary and critical care physician at Zydus Hospitals in Gujarat. Has over 40 presentations nationally, internationally, with more than 10 publications, including the ERG and CHEST. He's the elected governing body member of the Indian Chess Society since 2025, the executive committee member of the Society of Respiratory Medicine and Vadodara Baroda Chess Group, the executive committee member of the Indian Society of Critical Care Medicine Vadodara, has been felicitated by the Honorable Chief Minister of Gujarat for Gujarat Beyond Growth Awards in Ahmedabad in February 2026 for excellence in pulmonary critical care medicines and community health initiatives, has been awarded the Times of India Excellence Award in 25 April for excellence in pulmonary and critical care medicine, the Certificate of Commitment awarded by the Limca Book of World Book of Records in London for the work in COVID-19 in March, and felicitated by the Chief Minister of Gujarat, has received the prestigious Chess Foundation Grant Award in 2019 for presentation at Chess 2019 in New Orleans, organized by the American College of Chess Physicians, an ICS ERS travel grant for Best Paper in Paris in 2019. Multiple feathers on his cap, and this topic could be presented by no one else better than Dr. Neel. Before Neel starts his presentation and I hand over the session to him, I'd also like to thank Lupin for being our academic partners today and helping us in reaching as many people as we can. Thank you so much. And over to you, Neel. Looking forward to hearing from you and learning from you.
Thank you so much for the kind introduction, Dr. Avya. And as we'll start with the presentation, and followed by that, we'll have a very excellent panel with us who will be taking us through this discussion of using home nebulization with obstructive airway disease. I'll just share my slides.
Yes, sir. Your screen is visible.
Just screen is visible, right?
Yeah. Yes, sir.
Okay. Thank you so much. So the topic for today is using home nebulization in chronic obstructive pulmonary disease, obstructive airway diseases. And this we'll try to keep it as a case-based discussion to keep it more interesting. And we'll have a lucid panel discussion after this to discuss all the critical aspects related to this topic. So, as we all know, this is just a diagram to show you how the airway of a chronic obstructive pulmonary disease patient functions. We all know that, especially all the residents and the postgraduates as well as the consultants here, that once in chronic obstructive pulmonary disease, the airways are in a state of hyperinflation. And with every breath, there is breath stacking. And because of this, also due to the hyperinflammatory process, there is excessive mucus inflammation which is going on. And that leads to increased mucus secretions also in the airways. So whenever we talk about nebulization, before that, we need to know that this is the primary pathology. So all these individual steps we are going to target: the smooth muscle constriction, the airway inflammation, as well as the hyperinflation. So when this is as per the latest GOLD guidelines, when we say that this patient has chronic obstructive pulmonary disease, patient would have breathlessness, which is progressive, chronic cough, a history of risk factors such as usage of tobacco smoke, smoking or any other tobacco in any form, occupational exposure. In the current state, even the air quality index is so poor that even environmental exposure becomes a risk factor. Besides that, genetic factors are also there. So we then do a spirometry to confirm that this patient may have a diagnosis of chronic obstructive pulmonary disease based on the FEO and FVC ratio, as well as the post-bronchodilator FEO and FVC, we are able to tell that whether this patient has definitely got airflow limitation. Accordingly, we, based on the criteria of the FEV1, we'll be grading this patient as to the degree of airflow obstruction as gold 1, 2, 3, or 4. And with the ABE assessment, we'll be then grading as well as also telling that this is A, B, or E category based on the symptoms, the MMRC score, the CAT score, as well as the number of exacerbations the patient has. So nebulization therapy, there are good points about it, that it is one of the easiest modes of inhalational therapy. Minimum cognition abilities are needed. There is no actuation and inhalation coordination. Manual dexterity problems or hand strength is not required, and a wide variety of drugs are available. The disadvantages, it is time taking, costly, and there are maintenance and cleaning issues with the nebulization. When we say the term nebulization, so maintenance nebulization is chronic use of nebulization for more than 3 weeks at home. And home nebulization is an umbrella term that refers to even a short time use of nebulization at your home. So these are two terminologies we should know about. What are the right candidates for maintenance nebulization? So rather than giving you a list, we'll discuss case scenarios. So this is the first case scenario, 72-year-old male diagnosed with severe COPD, CAT score of 26, MMRC 3, on LABA-LAMA therapy with a dry powder inhaler, 0 to 1, almost around 1 moderate exacerbation in the last year and stable for months after that, but very frail, sarcopenic. Repeatedly, the patient is saying that, okay, my adherence is very good, but still says that I have a lot of morning dyspnea and no benefit with the dry powder inhaler. So this is one case scenario which most of you who are joining here would have faced in your clinical practice, and patient would have changed multiple inhalers. Patient might even have changed multiple doctors, but eventually then comes to you, then what do you do here? Like, is this a candidate? So here, when you check the inhaler, you feel that the steps are okay, but the patient's peak inspiratory flow is very low. The rate PIFR is less than 60 liters per minute. So this is one group of patients where the problem is not the failure of the drug or the pharmacology. The problem is the delivery failure. So this is one case scenario where there will be role of maintenance home nebulization. So suboptimal peak inspiratory flow rate, this has been studied in various journals where they've shown that the decrease in the lung function impacts the patient's ability to generate adequate capacity to use the device sufficiently. Also, PIFR decreases significantly during the time of exacerbation. So normally whenever a patient is getting discharged, the peak inspiratory flow rate is likely to be very low. So that is the time probably we have the role of maintenance nebulization. And rapid decliners and frequent exacerbators. So patients who have a rapid decline in FEV1 and patients who have frequent exacerbations, they are candidates where this may help. So this was the first case scenario. Second, again, 68-year-old female, severe COPD, FEV1 of 38%, CAT 22, MMRC of 3, 2 moderate exacerbations in the last year, now stable, has severe rheumatoid arthritis with hand deformities, and very mild cognitive impairment is also there. So patient did try using the MDI with spacer, but faces repeated errors and cannot actuate or coordinate reliably, and frequently there are critical errors which lead to poor usage of the inhaler. So here we see that the limitation is not physical, but it is not a motivation problem. That patient wants to use the inhaler properly, even probably understands it properly, but because of the physical deformity, because of the cognitive impairment, is unable to use the inhaler properly. So here again, this is the second category where there will be a role of maintenance home nebulization in this obstructive airway disease. Cognitive impairment could be memory, attention, and executive function. So various studies which have been published in COPD in the Journal of Brazilian Pneumology as well as the chest have shown that there is an impairment in memory, attention, and executive function. 36% of COPD patients present with cognitive impairment, and 12% in the general population, they have low adherence to medical treatment, increased rates of hospitalization, and increased rates of mortality. This was published in the Journal of Brazilian Pneumology, where they showed that there was significant relation of COPD and cognitive impairment, with especially the visuospatial memory, which was close to 26 to 20%, and cognitive was associated with the severity of COPD. There could be muscle weakness and impaired dexterity in around 40% of the patient where the exercise capacity was reduced, and strong association between the hand grip strength and the peak inspiratory flow rate, and the functional residual capacity, as well as the fatigue, which are all going down with severe COPD. So the third case scenario now, a 60-year-old male with severe COPD, chronic bronchitis, CAT28, MMRC 3 to 4, optimized with LABA-LAMA therapy, pulmonary rehab is completed, no exacerbation in 6 months, but still dairy breathlessness, and there is limitation of routine activity, no cardiac problems, ILD or anemia. Multiple times the patient has changed the inhalers, no relief. So this is despite taking appropriate therapy, patient has severe symptoms. So what are the options in this case? And this will also become a candidate for home nebulization therapy as well as some newer therapies. So when we talk about newer therapies, this was published in the International Journal of COPD of various targets. So normally you have trachea, bronchus, bronchioles. Now more and more we see there is more discussion on small airway disease. There is more areas of research, more newer molecules which are targeting the smaller airways, because what we have found is that despite taking appropriate inhaler therapy, a lot of times the drug may not be able to penetrate the alveoli or reach the smaller airways or the terminal bronchioles, which are only 0.6 mm in diameter. So then comes the role again of the nebulized medicines. We'll come to the various types of nebulizers. There could be the jet nebulizer, the ultrasonic nebulizer, and the mesh nebulizer. We'll be coming to these in the subsequent slides. Nebulized long-acting bronchodilators can be used as maintenance therapies and not only rescue, but it is appropriate on only the patient segment which I described, which is inadequately controlled by DPIs or MDIs, which are severe disease, and it provides an alternative route which avoids the need of inspiratory flow, manual dexterity, or complex coordination. A lot of times, higher dose is not only the dose of the drug, it is higher lung deposition, which can be achieved with appropriate use of nebulized therapy. When I talked about newer drugs, so ensifentrine is one new drug, which is a PDE3 and PDO4 inhibitor for treatment. This was studied in the ENHANCE trial published in the Blue Journal in 2023. It is a selective dual PDE3 PDO4 inhibitor, and especially for this studied patients between 40 to 80 years with moderate to severe symptomatic COPD. And amongst the 760 and 789 patients studied, it showed that when it was used, post-bronchodilator FEV1 predicted values were 52 and 51%, and ensifentrine improved the average FEV1 as well as the patient's symptoms and quality of life. And gradually, as compared to the other class of drug, this also promised to be a good molecule. Case 4, again 64-year-old male, severe COPD, chronic bronchitis, daily cough with thick sputum. So here we are talking about patients with predominantly chronic bronchitis and significant amount of sputum with morning congestion and airway plugging. So here you use a triple therapy, but still patient is unable to has repeated exacerbations with even oral mucolytics with minimum benefit. So the symptoms here are mucus driven and not the bronchospasm driven. So this is also one case scenario where there is rationale of mucolytic nebulization because it has higher local airway concentration, improved mucus hydration, enhanced clearance. There are various varieties of molecules such as hypertonic saline, N-acetylcysteine, which are available, which can help in this mucolytic property. Case 5 is recurrent exacerbations with multiple times same bacteria, such as recurrent Pseudomonas exacerbations, where the colonization is also documented in a stable state. Also, such patient could be on triple therapy. You have done all rehab measures, given recurrent oral antibiotics as needed, but still patient has only transient benefit. So here, there will be the rationale of nebulized antibiotic with higher airway drug concentration, minimum systemic exposure, and targeted suppression of the pathogen which is recurrently colonizing. And long-term nebulized antibiotics such as tobramycin or colistin, depending on the sensitivity as well as the local protocols. And in selective patients, it may reduce the exacerbation, especially because it targets the infective endotype. So this was studied in the Journal of COPD in 2012, which when it showed that all these case scenarios that we've discussed, cognitive impairment, manual dexterity, muscle weakness, inability to use the inhaler properly, inadequate symptom control, poor compliance, sometimes with, again, there are all these indications. So this is all regarding COPD. Coming to asthma. So Gina tells us this is whenever we decide the decision is not always the clinician's, not always yours. It is also with the patient. So it is for which patient, which class of medication to be used. So which inhaler is the patient currently on? Is there a non-adherence? Then we check which of these inhalers can the patient use correctly after training. Is the patient compliant once taught properly? Which of the agents also has the least environmental impact? And is the patient satisfied using the medication or inhaler? When in all this question, your answers are coming that, okay, patient is using it properly, but still the drug is not acting, then comes the role of nebulization where you can correct it based on your patient profile. So case scenario 6, 8-year-old female who's a school teacher, who's a known asthma since childhood, strong dust mite allergy, on again so ICS formoterol therapy, maintenance as well as reliever both. Patient has recurrent 4 a.m. weakenings with poor daytime control. So again, during nocturnal attacks, patient develops panic, tachypnea, poor inhaler coordination, and is unable to get relief. And there is a dip in the peak expiratory flow rate in the morning. So again, this patient has uncontrolled asthma with strong dust mite allergy in a pediatric patient. So again, here nebulized salbutamol or also an action plan should be there. And here in this particular scenario, it is not chronic maintenance, but a rescue bridge therapy, especially for the nocturnal bronchospasm that we are using the short-term nebulization. This is with a word of caution because as per the GINA 2025 guidelines and whatever data that we have, if somebody is on regular SABA therapy, it causes down regulation of the beta receptors and decreased action, accordingly causing increased requirement. And frequent use of SABA, that is up to 1 canister per month, it increases the risk of emergency visits, even the risk of death. That is as per the latest GINA guidelines. This is specific to continuous use of SABA therapy. So again, coming back to this are the risk factors listed by GINA. So again, if you can make out, this is that if the fourth point, that is the overuse of short-acting beta agonist, especially average of more than 1 canister of salbutamol or nebulized SABA, this is associated with asthma-related. So that is why we have to be careful of the molecule we are using, and especially no long-term SABAs when we are using home nebulization. Case 7, again 31-year-old pregnant female, second trimester, moderate persistent asthma with reflux, hyperemesis symptoms are there, has a lot of nausea, gagging and cough. Symptoms worsen during the evening and patient is very afraid, very apprehensive of using any medicine. So that affects the adherence. So here a short supervised course of maybe a budesonide course during the unstable period or salbutamol need-based, it may help with the barrier that the patient has because of the pregnancy, and it also will help that if with the inhaler use, patient has a lot of nausea, that also improves. So temporary adherence can help with usage in this particular population. What GINA tells us that in patients with pregnancy, the advantages of actively treating asthma outweigh the risk of any usual asthma medications. And any planned pregnancy when there is there, patients are advised not to stop ICS containing therapy, especially during labor and delivery, maintenance medication, reliever as needed. And again, during exacerbations, nebulization can be used, especially because that time it is important that patient's respiratory stability is achieved during that procedure also. Last case, 14-year-old boy, exercise triggered viral asthma, adolescent, inconsistent spacer use. Parents report that worsens with the upper respiratory tract infection and patient refuses the inhaler use. So again, here emphasizes that as per the real world adherence of the child, you need to use the nebulized therapy as and when needed. So these are all various case scenarios to highlight the indications. Important is the patient's comfort for better symptom relief. You need to see what is best for your patient and what is the preference of the patient or the caregivers. A lot of times studies have shown satisfying experience with nebulization, but again, this can vary. These are some results from various studies. Which drug may be used? You can have bronchodilators, steroids, antibiotics, mucoactive agents, pH drugs. All of these we studied in various case scenarios. This is a Indian data from the European Society of Medicine published by Dr. Rajadhar and the entire team, where they studied NOVA-ER, the nebulization optimization in management of obstructive airway disease. COPD was divided into 3 segments of symptoms: intermittent symptoms, acute exacerbation, and preventive exacerbation. Intermittent symptoms were treated with LAMA or LAMA-LABA. acute exacerbation, SABA-SAMA or LAMA, prevention of exacerbation with LABA ICS as home nebulization. What this studied was the frequency of error, even not only in the patients, but also in the caregivers, be it the doctors, be it the nursing staff, be it the pharmacist. The data is alarming that 96% of the pharmacists, 88.5 nursing staff, and 40% doctors were making errors when we are using inhalational therapy. And various steps were studied, and predominantly inhaling, the step of inhalation was incorrect or holding was incorrect, but various errors with inhalation were there when comparing DPI, EMDI, as well as spacers. So again, there comes the role of nebulization where the number of errors may be reduced. So in all these symptoms, these various formulations can be used. Patients who require higher doses, who have poor response to PMDI, acute exacerbation with severe hypoxemia, and pediatric patients who are unable to use MDI. So all these various steps, we need to identify what is the cause, what is the intent here. Is it bronchodilation? Is it mucus clearance? Is it recurrent infections? Based on the number of recurrent infections, we can use the antibiotic tobramycin or colistin nebs as we've discussed. And patient with frequent pseudomonas, we need to check whether with usage of this, the cultures are now negative or not. So when next comes, we have to choose what is the best nebulizer. So there could be jet, ultrasonic or mesh nebulizer. What we know about the jet nebulizer, the mechanism, the air comes in, there is compressed air source, and the medication then comes out through the air to the patient. This nebulizer we have all used in the hospital, which is being used. There are breath activated jet nebulizers also, as you can make out in the figure, where you have a breath actuated mode with the patients taking the breath, the nebulizer is activated. So that is also a mode which is used with the jet nebulizer. Ultrasonic nebulizer, there is a power transmitter with a piezoelectric transducer. With the acoustic waves, the aerosol then goes to the patient. There is the mesh nebulization, which has now got the latest developments. Now even portable nebulizers are coming through, where you are using a interface of liquid and air through the droplets, and the mesh assembly, there is a vibrating mesh with a piezoelectric ring actuator or holder, and you could have various different assemblies using this mesh. So it could then help you with the mesh nebulized aerosol delivery. So all these nebulizers are compared. The time taken with a mesh nebulizer is 1 to 5 minutes, 10 to 12 minutes with a jet nebulizer. Highest output is with mesh nebulizer. Every clean after use, you need to clean with a mesh nebulizer as well as jet nebulizer. Ultrasonic, you can do after a number of uses. Cost overall is highest with the mesh and the ultrasonic nebulizations. Portability is easiest with the mesh nebulizer, and the sound is silent. So various, we need to choose again based on our patient's profile as well as what are the particular case situations. Pre-nebulization, what do we need to take care? We need to fill the volume not less than 2 ml, because again, residual volume cannot be nebulized and therefore is not available for the patient. So initial volume more than 2 to 4 ml ensures the drug availability to the patient. Dilution can be done. This is again for the hospital normal saline. If you are at home, either normal saline or sterile water, both can be used. The normal water that you use, it can cause paradoxical bronchospasm. So if you have to choose between the two, normal saline would be better. And respules do not require dilution a lot of times, and respiratory, and a lot of times the dose per session should be as per your prescribing doctor's instructions. And drug combination should be that both the molecules or respules that you are using should be compatible. When you use, you need to have a proper posture, sit upright, hold the nebulization cup upright and comfortable to allow maximum delivery. You need to breathe deep, holding the breath. Again, this is normal. Tidal breathing can also cause good delivery of the drug. And patient, if has a lot of cough or starts to take out of the phlegm, then you can stop the nebulizer during that time. Occasional tapping of the medication in the chamber also helps with good delivery, especially to bring down the bigger droplets which are sticking to the walls and increasing the drug available for nebulization. Cleaning, we can use a water mild detergent. You can use isopropanol hydrogen peroxide after every use, sterile water, and clean and dry the area after use. And again, there are various guidelines for cleaning the nebulizer. You need to wash the hand properly, disassemble the nebulizer, wash the medicine cup, the mouthpiece and mask with warm water and soap, rinse well and air dry with a clean paper towel. Indian guidelines recommend boil parts 5 to 10 minutes or soak in ethanol or vinegar water or rinse with sterile water. Avoid cleaning the tubing, replace if it is dirty. Weekly disinfection can also help, and regular replacement if you feel that the parts that the mask or tubing is getting infected. Do's and don'ts: we advise the patients to have a full supply of medication. When the room care, you have that a lot of the patients are living together, patient as well as caregivers. We need to ensure good aeration, especially if the patient is infected. And while using the nebulizer, especially during COVID pandemic, it was that the or any acute viral infection, you want that the caregiver should be at least 6 feet from the patient, and it should be a well ventilated room. Family members should not ideally share nebulizers. Avoid air conditioning during using the nebulizer if possible, and wash the accessories and clean as per the criteria. So we've discussed with the guidelines and most of the points regarding inhalational therapy with COPD patients. We'll discuss this in the panel. There are treatable traits. Now the ATS and the AJRCCM recommend the approach should be by the trait. So if there's a pulmonary trait, airflow limitation, emphysema, eosinophilic airway inflammation, chronic bronchitis, we don't target the disease, we target the trait in the patient. Nutritional or the extrapulmonary can be tackled with good pulmonary rehab programs. And so in conclusion, nebulization, where do you use in patients who do not require coordination, errors will be less. In patients who are elderly, COPD patients who are unable to use the handheld inhalers properly, cognitive impairment, poor lung condition, asthma should be selective, short purpose and phenotype driven, not a replacement for inhalers. Benefits can be optimized through proper patient selection, a good appropriate prescription with the type, the drug use, the dosage, and the instructions around the nebulization, such as which steroid we advise gargling. Accordingly, such instructions should be given. Counseling the patient and caregivers properly. Thank you so much for your patient listening. Now we'll proceed to the panel discussion.
That was a fantastic talk, Neel. I think you've clearly elucidated the entire aspect of home nebulization in about 30 minutes, right from the medication used to the nuances to the new devices, new molecules, and combination. Excellent talk. I think our panelists and our audience are completely thrilled with what you've said. A very good learning and insightful presentation. Now, we've got a power pack panel, and I'm going to pick their brains with a lot of questions which I've set up after listening to Neel and his talk. Without wasting further time, I'd like to introduce our panelists. We've got Dr. K.K. Shyamala, madam. She's our first panelist. I'd like to introduce madam. Madam, welcome.
Thank you, sir.
Can we have a presentation slide, please?
Yes, sir. Sharing, sir.
Thank you.
Sir, my screen is visible?
No, it's not. Yes, now it is visible. Thank you so much. So, madam is a professor and head of Department of Respiratory Medicine at the B.R. Ambedkar Medical College in Bangalore. Madam has the advanced course in medical education from St. John's, Bangalore, has been a present designation of the Ambedkar College. She's a convener of medical education unit at BRAMC, has a total experience of more than 20 years in the field of pulmonology, has a special interest in sleep disorders, asthma, COPD, TB, and pleural disorders, has more than 10 publications, is a member of the ICS, ERS, IMA, and Karnataka Pulmonology Association, is the ex-nodal officer of NTEP at the BRAMC, was the COVID task force chief at the BRMC in the second wave of 2021, has been a resource person for workshops held at AMCH, the basic course in medical education, curriculum implementation support program, comprehensive emergency life-saving course, the Jiva Raksha, the RGHS course for interns, and the TB sensitization program across PGs, interns, and nurses, and was a part of the PMS study for formoterol mometazone. A very warm welcome to you, madam.
Thank you, sir.
We have next Dr. Vishakha Kapadia, madam. She's an associate professor at the Department of Pulmonary Medicine at the SVP Hospital and the NHL Medical College, Ahmedabad. An affluent speaker and very well interested in the management of airway diseases. A warm welcome to Dr. Vishakha Kapadia.
Thank you, sir.
We also have Dr. Saurabh Ojha with us today. Could we have his slide, please? Dr. Saurabh Ojha is the consultant and head Department of Pulmonary Critical Care and Sleep Medicine at Globe Healthcare in Lucknow. Another passionate speaker and very well interested in the management of airway diseases. A warm welcome to Dr. Saurabh Ojha. And finally, we've got Dr. Akshay Kawedia. who's an MD Medicine, DM Pulmonary Critical Care from AIMS New Delhi, has an area of interest in airway diseases, allergic pulmonology, interventional pulmonology, and sleep medicine. Was the All India rank 1 in pulmonary critical care and sleep medicine in 2023. Was first in the NAPCON 25 quiz competition and the finalist in the oral paper at NAPCON 25. At AIMS Panmukhe 25, placed third in the poster competition, was first in PACS, first in symposium competition at JJ, second in the symposium at Illuminati 2014 at AFMC, and is a member of the ERS, ATS, ICS, and IAP. So, our youngest panelist, warm welcome to Dr. Akshay Kawedia. And now we can start
I
the
think
discussion.
we'll have the slide for Dr. Avya Bansal, please. So I have the pleasure of introducing our moderator for today. So Dr. Avya Bansal is a very good friend and again a consultant pulmonologist, sleep disorder specialist at Bombay Hospital, honorary pulmonologist with the Mumbai Police, Lung Care Clinic, Bandra. Sir Ratan Tata Scholarship in MBBS, University topper in MD. He's got the ICS travel grant in Madrid in 2019, ERS training in ILD in Germany, pediatric asthma in Austria, and PH in Netherlands. So he's covering all the areas of pulmonary medicine with different areas at Europe. He also has a special interest in obstructive airway disease, OSA, and ILD. He set up the adult vaccination OPD at Bombay Hospital, set up a sleep clinic there. He set up a severe asthma clinic at Bombay Hospital. He's the ET Times Now Inspiring Respiratory Specialist of India in 2024. And also, from what I know, during the COVID pandemic, he was the young face of pulmonology in South Bombay. So he was like treating a lot of police people as well as all the various patients there. So warm welcome to Dr. Avya to carry out this panel.
Thank you so much, Neel. Thank you for those kind words and warm introduction. Okay, so I'm very excited about this panel discussion because very often we have not just pulmonologists, but physicians, general practitioners, alternate medicine doctors prescribing nebulization left, right, center to patients. But what are the nuances about nebulization? How do we take it forward? What are the indications, contraindications, drugs involved? What medicines need to be used? How long to give it? These are all important questions which sometimes even we sit back and wonder, are these drugs which are mixed together working? Are they compatible? Are they having an adequate drug delivery? When do we step up? When do we step down? So for all these burning questions, I've got a power packed panel, and I'm going to start with Dr. Shyamala, madam. The first and most important question is, when do you prescribe home nebulization in obstructive airway diseases?
First of all, I would like to thank Dr. Amita Madam and ICS for inviting me for this hardcore topic of home nebulization in obstructive airway disease. And coming to the use of the prescription for the home nebulization in patients with obstructive airway disease. So this is especially, it's increasing and trend in the current respiratory practice. And it's preferred especially in set of target populations. Already Dr. Neel Thakkar has highlighted, especially in elderly patients with a cognitive impairment and who are having a poor handled coordination between the breath and the device, and with a severe airway disease and poor inspiratory flow. Patients who are actually requiring high dose of the bronchodilators or the corticosteroids, and who are not unable to use the regular other devices, they are preferred, and also not responding to the current treatment what they are being prescribed. Patients with the frequent exacerbations are also being considered for the home nebulizations. Patient having even poor neuromuscular conditions, weakness, and also being considered for the home nebulizations. Yes, sir.
Thank you, madam. So also we need to remember is that when we prescribe nebulization in obstructive airway disease, we need to be very, very sure the target population we've covered.
Yes.
There are antibiotics which are nebulized in bronchiectasis, which is typically tobramycin for Pseudomonas eradication.
Yes.
That becomes it. That's something which you can't substitute in an oral form for a long period of time. Also, patients who've been exacerbating recurrently and repeatedly, and we require an adequate drug delivery which cannot be achieved with an inhaler, MDI spacer, or a dry powder inhaler. These become certain prerequisites to nebulize obstructive airway disease patients. Also, the pediatric patients and the geriatric patients who very often do not have a proper coordination and adequate delivery. Now that becomes the cornerstone for nebulization in obstructive airway diseases. Now, Dr. Vishakha, moving on to you, do we have a certain set list of conditions? I know Dr. Neel and Dr. Shyamala have spoken about cognitive issues and coordination issues, but if you need to finalize and tell us that, look, these are the things which we need to understand, these are the strict indications for prescribing nebulization at home, what would those be?
Uh, so, uh, Thank you very much, Dr. Anita ma'am, for giving me this opportunity. Uh, for nebulization at home, for the patient of when we give high dose of the drug, we need to give nebulization that patient, and all of the indications already told by Shyamala madam. So, in patients in whom we are giving mucolytics, which we cannot give by uh, ne- uh, uh, tablet form or oral form, and not improved after tablet. The cases which have been shown by Dr. Neel. So, in that case, we can prescribe nebulized form of the this mucolytic. And in patients with cystic fibrosis, like bronchiectasis, and all these patients, when we want to give prolonged antibiotic at home, in that cases also we need to give home nebulization treatment for the long term.
Very well said, Dr. Kapadia. So first and foremost, we need to understand that what is the target population? Is it a pediatric patient who's been wheezing, who's got a wheeze-associated lower respiratory infection, or we've got a geriatric, poor cognitive individual with a poor inspiratory capacity? The normal individuals or the so-called younger population who've been having recurrent exacerbations or have had an exacerbation episode at home can switch over to the nebulization. That becomes an indication. And when you're prescribing nebulized antibiotics, very often, like we said, that patients who've developing a lot of sputum or producing a lot of mucus or mucus clearing agents, sometimes tablets do not do well. And at that point of time, mucolytic nebulized form coupled with airway clearance and chest physiotherapy does help to improve their symptoms. Right. So, Dr. Saurabh Ojha, now we've spoken about the indications of home nebulization. We've had multiple speakers repeat those points and hammer it down our delegates and audience. Now, what are the contraindications for nebulization?
Yeah, thank you, sir. At the onset, I would like to thank Dr. Amita ma'am and ICS for organizing this amazing webinar. During our time, we did not have this available during our both MD residency. So this is something which has caught my eye. Now back to our question. So absolute contraindications, only two are listed so far. One is hypersensitivity to the drugs like albuterol or budesonide which we are using. Second is medically unstable patient. Supposingly he's in complete shock, we are not going to be able to give him nebulization. Now we need to intubate immediately. Rest all are relative contraindications like a patient with facial trauma or burns. That will be too much irritation for him. He won't be able to tolerate. There is severe uncooperative patient with agitation and combativeness. So we cannot tie him up and give him the nebulization. For patients who have narrow angle closure glaucomas, sometimes nebulizations with a muscarinic agent can precipitate the glaucomas. And one specific scenario is supposingly there is a disease like post COVID pandemic something, and we cannot use that nebulization in a shared space. So for now, I think, sir, this should suffice.
Yes, so very well said. When you want to prevent cross contamination and spread of aerosol and aerosol generation in a closed environment, that's the time you would advise against nebulization. But yes, if you've got a negative suction room, then at that point of time, that can also be considered. Also, when a patient is having an active hemoptysis episode, when there is a frank blood, which is patient is coughing out at that point of time, if you've got an obstructive airway disease, you would prefer an MDI with a spacer just so that the triggering of the airway doesn't happen at that point of time, which the nebulized particles can cause a stimulation of the airways and produce a cough reflex, and the patient may eventually end up coughing a lot more blood. Also, post-operative patients, sometimes, our geriatric patients are on home nebulization and undergo cataract surgeries. At that point of time, we need to be very careful and tell them that post the cataract surgery, either the eyes need to be closed when they're taking the nebulization and the eyes need to be covered completely because the nebulized medication and the aerosol can also act as an irritant in those situations. But yes, completely comatose patients, uncooperative patients, or allergy or hypersensitivity to the drugs become the absolute contraindications. Akshay, what are the common side effects which you've encountered with patients on nebulization?
So first, I'd like to thank the Indian Chess Society and Amita Nene ma'am as well as Rakesh sir for the opportunity for this webinar, and also to Neel sir for such a crisp lecture on the topic. Coming to the common adverse drug reactions, when you go to see, we can divide them actually into three types: so due to the drug, to the delivery, and due to the device. When we come to the drug, it can be due to the different drugs, such as beta 2 agonists can cause tremors, hypokalemia, as well as patients can have tachycardia with them. With inhaled corticosteroids, oral candidiasis and throat irritation, as well as hoarseness of mouth is really common. And with anticholinergics, as we know, dry mouth is one of the common side effects, as well as we should know that it can precipitate angle closure glaucoma if the mask fit is not poor and there is an exposure to the eyes due to the drug. Due to the device itself, if there's improper cleaning, there can be infection due to organisms such as pseudomonas, which can cause a biofilm which can be formed onto the device itself. And also because of this itself, there will be an improper delivery to the improper delivery of the drug itself, leading to a more symptom burden to the patient itself. And coming to the delivery, if you're using a wrong drug in a wrong nebulizer, for example, if you're using something like a denatured drug, such as like an antibiotic or a budesonide in an ultrasonic nebulizer, we can have conditions where there is not appropriate delivery. So these are the common scenarios where we can have these are the adverse drug reactions which we can see in these patients.
Right. Also, what we need to remember is the dose of the drug in the nebulized form or in the nebulization suspension solution is higher than what is typically prescribed in your MDI or DPI. And therefore, the side effects encountered with an MDI DPI are multiplied when you give a nebulized form over a period of time. Also, telling the patient specific instructions of gargling, rinsing the mouth is often neglected, and they tend to forget those things. So, the incidence of thrush is definitely higher in patients who've been nebulized for a prolonged period of time. Very well said, Akshay, with respect to infections, because cleanliness of the nebulizer becomes so very important, and not just bacterial infections, but fungal infections as well, contamination of the nebulizer itself. Sometimes there is residual water which is left, and the residual water after cleaning, or the residual medicine which is left, and patients reuse it multiple times, and eventually that becomes a source of infection and contamination. So, Neel, in your busy practice, I'm sure you prescribe a lot of nebulization when indicated to your patients. So, do you follow a set of instructions which you give to the patient, or if the patient is not able to understand, do you tell the primary caregiver that these are the do's and don'ts which you need to understand when prescribing a nebulizer?
Definitely. So we follow this for our own patients, that when we are writing down a drug, we use a prescription. So whenever we are using nebulization, we see that the normal thing that we as even pulmonologists tend to write is that this so and so nebulization 1 or 2 times a day, and maybe if steroid is there, then use gargles or accordingly. But ideally, whatever, when we talk to a patient where the comprehension is poor, or what we ideally should be doing, even when we take sessions for general practitioners around us, or if your physician colleagues you need to tell them that when you are using nebulization at home, number one, there's an acronym that we come across, that is nebulize itself. So you name the drug clearly. N is for naming the drug. You mention the exact drug, the dose, as well as the dilution that we using with sterile water or saline, or accordingly what is the dose, what is the content of the drug. You explain the purpose to the patient properly, that this is your indication. If you have COPD, then this is only for rescue medication, this is maintenance, and this is just as a bridge for some time, and then we'll switch you to inhalational therapy. The breathing technique, so N is the name, E is explaining the purpose, B is the breathing technique. You need to make sure that the patient is sitting upright and has quite tidal breathing, and doesn't hyperventilate with the using of the nebulizer, because that can aggravate or cause a gagging cough again, even with the nebulizer. U is for using the correct device. So proper mask or mouthpiece, whichever nebulizer you use as per the patient. Appropriate type. So gradually we are coming, initially every nebulizer was a jet nebulizer. Now with the variety of nebulizer machines available, eventually it is going to be this particular type of machine. So mesh nebulizer, jet nebulizer, ultrasonic, whatever the best nebulization, with the variety of options which are available now. Limiting overuse. So L is for you don't have unsupervised repeated nebulization cycles. There are patients who come in with atrial fibrillation just because they have been taking themselves nebulization for a long time. Patients who come in with tremors, other side effects because of, and like I showed in the study, long-term use of SABA increases the risk of mortality if continuously used. Infection prevention. We need to make sure that the chamber is clean, masks are dry, and it is not shared. S is you rinse the mouth with, whenever you're using a steroid nebulization, rinsing of mouth or gargling is important. and E is for escalation. So you need to advise the patient to escalate, and whenever if the frequency of nebulization increases, you need to seek urgent medical care. So nebulize acronym, name the drug, explain the purpose, breathing technique, use the correct device, limit the overuse, infection prevention is important. Whenever using steroid, rinse the mouth and escalate when needed. So this acronym may help for patients that time.
Yes. So very well said. Also, what we need to remember and focus is that we need to give specific instructions when we write down the prescription, the dose of the inhaled medication and the duration for the inhaled medication. It can't be given indefinitely unless you plan to give it for a week, 10 days, 15 days, 2 days, 3 days, whatever it is, it needs to be put down on paper. How long the patient needs to nebulize. These are very common mistakes which patients often make or doctors forget to communicate to the patient or the primary giver.
And Dr. Avya,
Coming
we
to this
mentioned
case.
about fungal infections in the previous question.
Yes.
So nowadays, if you see, we find a lot of patients not only airway candidiasis. So
Esophageal
I
candidiasis as
had
well,
a series
yes.
of patients, chronic airway disease patients, who had some reflux issues. They underwent an endoscopy and they found that patient has esophageal candidiasis because so we need to be very careful when we prescribe, especially long-term inhalational use.
Yes, also the incidence of esophageal candidiasis increases if the patients don't rinse and drink the water. So that increases the risk of esophageal candidiasis. So we must always tell them that they need to rinse them out and spit it out, not to swallow it or ingest it. This is one mistake which patients make. I want Dr. Shyamala to tell us what are the other common mistakes which patients often make or caregivers make when we talk of nebulized
Oh, yes.
medication.
Yeah, I think Dr. Neel has clearly talked about the instructions. Most often the patient fails to follow this, and especially the dosing and the frequencies are also been they follow as like their own way of controlling the symptoms. And coming to the device maintenance, and most often it has not been taken care of, so patient's cleanliness. So the devices are unclean or this things that tubing is clogged or the tubing is contaminated or worn out. These are some of the other things which patient often don't follow. And air filters is again other which needs to be regularly looked into it, which is often missed by the patients. And of course, the technique which Dr. Neel has already told, the proper sitting postures and breath holding and these have been some of the things which I feel the patient should be taken care of to avoid all these common mistakes.
Well said, Dr. Shamla. Also, what we need to tell them is how do they store the nebulized medication? Very specific instructions have to be kept, not to keep it outside, not to keep it in sunlight. You need to keep it refrigerated, keep it in the fridge, not in the freezer. Otherwise, the potency and the efficacy of the nebulized medication goes away. That's
Yes.
something which we need to tell them very importantly, and also the way to discard the used respules
Used
and to
solutions. Yes.
yes, and how often they need to change the nebulized mask, that also needs to be told to them. So these are
Exactly.
common mistakes which patients often make while using long-term nebulized medication. Now,
Exactly.
Dr. Vishakha, we've got so many nebulized medications, and often patients are prescribed more than one nebulized medication. Can we combine these medicines with each other? If yes, what are the combinations which work well with each other?
Yes. So commonly when we are prescribing like short-acting beta-2 agonist and long short-acting cholinergic agent, then it can be combined like it's available already, and even budesonide can be also added. But in routinely we are doing this SABA, SAMA, and ICS we are using. But mucolytics, when we are giving additionally, it should not be combined. And if we are giving mucolytics, then we have to give bronchodilator first, and then we have to give mucolytic agent. So it can increase and improve the lung clearance. And nowadays, long-acting beta LABA/LAMA is available. LABA, ICS plus LAMA. These rescues are also available. So compatibility should be checked before combining all these agents. And nowadays, the combination of the drugs are available. So now it's easy for us also and for patient also, so they can use it properly in proper doses.
Yeah, so well said, Dr. Kapadia. So yes, we can mix nebulized medication. We've got different combinations. Conventionally, we had ICS separately, which was budesonide or fluticasone with a combination of a SABA-SAMA. But now you've got a LABA-LAMA combination. You've got a LABA-ICS combination. You've got a LABA-LAMA-ICS combination. So yes, all of these three groups of drugs can be mixed with each other and used safely, provided the efficacy of the combination has been established by the parent company. Number one. Number two, well said that the mucolytics should not be mixed with the conventional ICS, LABA-LAMA or SABA-SAMA medication, and you must always give a nebulized bronchodilator, if not an ICS, at least to the patients with mucolytic nebulization, because they can trigger a reflex bronchospasm. Also, we must not mix nebulized antibiotics with any of these drugs. We must have nebulized antibiotics given separately. If you've got patients who are requiring nebulized antibiotics and are on bronchodilators, ICS, and mucolytics, each and every component of the drug should be separate. And typically, nebulized antibiotics should be prescribed after giving the mucolytic and after having a session of physiotherapy so that the maximum amount of mucus is drained from the respiratory passage. Okay, now we've started the patients on nebulization, we've understood how to use, we've given them instructions. Now, the most important question to Dr. Ojha is that how do we monitor these patients on home nebulization? How do we follow them up?
So first of all comes the clinical assessment. So one of the very common methods which we have been knowing and studying is peak flow measurements. Ideally, it is recommended that 15 to 20 minutes before and after the nebulization, we should advise our patients to take a peak flow measurement device and measure it. Other is heart rate and rhythm monitoring. We should teach our patients how to check their pulse. So if there is too much tachycardia or pulse variation, we can accordingly reduce the doses also. Then there is a symptom diary in which the patient will write their symptoms, how they are feeling, the dyspnea levels and the improvement they have seen. And we can check it through the CAT scoring and ACQ questionnaire also for further objective assessment. Now the next is very important is equipment and technique which we are using. So for adherence, so one is mist check. So once we are using the jet nebulization, we have to check whether the mist, there is too much mist. In certain cases, because of repeated using, the entire jets and the airways can get clogged in it, the pushing mechanism. So we have to check for that. Other is the cleaning compliances. Most of my patients I have seen, they will just run it through the tap water and that's it. They are not exposing it to dry air. They are not letting it dry properly. Other is whether they are using the mask or they are using the mouthpieces. That is also very essential. What posture they are using, in a lying down posture or they are sitting comfortably. Supposingly they have irritation, dry eye or a glaucoma patient, we have prescribed llama combination. So these are some basic things which we need to assess, and it is a very, very essential tool and very, very important step for anyone who's prescribing home nebulization. I just checked a question in the chat box. A doctor has written, what is the rationale of long-term monitoring? It is very, very crucial. Otherwise, we are just going to have, we are prescribing them for comfort, but they are going to land up in exacerbation repeatedly.
Also, what we need to understand is whenever our patients are on long-term nebulization at home, it almost becomes a given and mandatory for them to be having supervised physiotherapy sessions and airway clearance techniques. Now, at that point of time, the functional capacity and the functional assessment of the patient becomes of prime importance. The MMRC grading of breathlessness, the sputum production, the chest tightness, wheezing are all important symptoms which should be assessed prior to starting the nebulization and while the patient has achieved a steady state. Apart from that, the inspiratory capacity with a spirometer is also what tells us whether the desired effect of the nebulization has been achieved in these patients or no. Very often, these patients have got a very, very poor inspiratory capacity of less than 10-15 liters per minute, and gradually with nebulized medication, that can improve and can always tempt us to go back to MDIs with spacers in this group of population. So monitoring becomes important for not only stepping down therapy, for stepping up therapy, but maintaining therapy and also switching between a nebulizer and coming down to a inhaler with a spacer or even a DPI in future. We need to understand that the cost of nebulized medication is far superior, maybe 5 times to 10 times higher than the cost of a triple combination inhaler in these patients. So we have to be mindful before we prescribe a long-term nebulizer to these patients as well. Now, having said that, Dr. Akshay, how do we step up therapy in patients on a home nebulizer? How do we've learned about monitoring, and how do we step up, and when do we step up therapy in these patients?
So as Dr. Ojha rightly said that we need to monitor these patients very frequently. Important to note that before stepping up, we need to look at the adherence as well as the technique, correct for the correctable factors, such as if a patient has OSA, we should do a sleep study. Look for triggers in case of patients with asthma. We have subjective assessment as well as objective assessments. In case of subjective assessments, we look for the MMRC score for dyspnea, the CAT score, as well the ACQ. If they are worsening rapidly, this is the time when we look into changing over to a nebulization therapy or stepping up therapy. Also, we need to look if there are frequent ER visits or exacerbations which are taking these patients, then we need to also consider to stepping up therapies. In terms of objective ones, we can look into the peak expirate peak flows that we can be monitored routinely, as well as the lung function in the form of FEV1. Important to note that it also nebulization considers nebulized antibiotics. So in patients with bronchiectasis with a sputum which is positive with the pseudomonas, we should consider for nebulized antibiotics as well in these cohort of patients.
So we must remember one thing is that patient on a nebulizer may not be essentially a step 4, step 5 asthmatic or a COPD group E patient, may just have poor coordination or maybe an elderly geriatric patient. So we must be very mindful before we step up therapy in these individuals. The purpose of starting the nebulizer should be different, and the dose and duration of nebulization should be different. Essentially, like Dr. Kawedia very rightly said, is we must understand before stepping up whether we've ruled out all other comorbidities and whether the compliance, technique, and adherence had been achieved. The same funda which we follow before stepping up therapy in asthma and COPD has to be understood while monitoring patients on home nebulization. Neel, we've spoken about monitoring and stepping up. First, an important question is, are you comfortable in stepping down therapy on nebulized patients? And if yes, how do you step down therapy in them?
So again, it depends on the type of the disease that we are dealing with. So in my case presentation, I dealt with almost 8 to 9 case scenarios where various cases where the patient needs home nebulization. Now, suppose there's a permanent disability that the patient has a rheumatoid arthritis, the patient is not going to be able to have dexterity to hold the nebulizer or has cognitive impairment, then definitely the answer is clear that because it's a permanent disability, eventually you will want the nebulizer to continue. In patients where there is a temporary issue, where in suppose COPD, the patient's disease is very uncontrolled, you have optimized the therapy with nebulization, patient had a recent exacerbation, on discharge you prescribe nebulization, probably 2 to 3 months, patient is then completely stable, no exacerbation, need for rescue medication has gone down, the inspiratory flow rates are very good, the CAT score is improving, no nocturnal awakenings. So that is probably a patient where I would do a PFT eventually and switch the patient to an inhalational therapy. And again, because COPD, so again, we would prefer a LABA-LAMA combination unless patient has significant eosinophilia as well as significant phenotype where the patient may benefit from triple therapy. Otherwise, in patients with asthma, again, the duration of therapy will be limited to the rescue time or as a bridge time between the patient when the patient improves. Once the patient control is maintained for more than 3 months, no night symptoms, no reliever overuse, PFR remains stable, patient doesn't have exacerbations, then in all this, you eventually want the patient to be on MARD therapy, that is a single ICS and LAMA therapy. Probably the patient, if improves, and in certain cases, like I said, even in asthma, you have a certain category of patients where triple therapy would help. But again, specifically in asthma, we should not encourage long-term blind nebulization because eventually if the patient control is good, the choice of inhalational therapy long-term for asthma is going to be inhalers only. For bronchiectasis patients, again, that's the third phenotype with recurrent infections. Short-term, definitely once the secretion reduces, airway clearance is effective, number of infective exacerbations come down, you will then switch back to either no inhalational therapy or whatever the airway disease accordingly. Same goes with any. So in most of the other conditions, you won't require a long-term nebulization. Your goal will be as a bridge to the patient's stability. Otherwise, mainly long-term is with COPD patients where you tend to have patients on long-term or with cognitive impairment or pediatric patients. That is also one segment where you use nebulization frequently.
Also, what we need to understand is that there are two aspects to stepping down therapy. Number one is stepping down the drug, and the number two is stepping down the drug delivery system. So you make step down from the drug delivery system, that is a nebulized form, to an MDI with spacer or a DPI. That's one form of stepping down therapy where you know that the patient has a good inspiratory capacity, but doesn't require a nebulized form anymore and can achieve stability even with a different drug delivery system. The other aspect is you know that this patient cannot be given an MDI and spacer. However, the symptoms are under control, and right now we can step down on the drugs. So both parameters need to be looked at simultaneously and periodically assessed in patients. That's the drug delivery system as well as the drug. Now, Dr. Shyamala and Neel has already covered this, but for the benefit of the audience, and I'd like you to repeat, what are the types of nebulizers at our disposal and the purpose of each of them?
There are three types of the nebulizers. The jet, the compressor type, it's the most commonly used by most of the patients. And it's used for wide applications for using all types of the nebulizer drug forms, the solutions or the suspensions. And it's very economical. And the other is the ultrasonic type of the nebulizer, which uses the sound waves, high frequency sound waves. And the nebulizer time is usually shorter in case of ultrasonic and produces a very fine mist thing, but its application is very limited. And I think as we cannot use the other types of solutions, suspensions, and especially it's more applicable used in case of sputum inductions. And the other nebulizer, which are the more recent and advanced, is the mesh nebulizers. Again, we have the active and the passive vibrating mesh, which produces highly efficient and small, finer particle size. And the nebulizer time is very short and 1 to 5 minutes. And it's applicable to use all the drugs except for the suspensions like the corticosteroids. So hence it's very important to choose the nebulizer type according to the patient convenience. And only the problem with the mesh nebulizer, it's very expensive. Everything, though it is very compact for individuals who can use it while during travel, and it's very highly useful in sense.
Yes, so very well said, Dr. Shyamala. She's spoken about jet, ultrasonic, and mesh. But what we need to remember is before we optimally choose a nebulizer, we must understand the drug we are going to be using in the nebulizer. That the nebulizer has a very low residual volume at the end of the complete session. And secondly, the time duration for the nebulized medication to reach the airway delivery system. So the time taken for the nebulized medication to reach the delivery system, that's the airway passage, and the residual volume has to be minimum, which is why an ideal nebulizer in today's day would probably be a jet nebulizer. Your breath actuated nebulizers are also coming. You also have recent advances in smart and Bluetooth connected nebulizer, which tell us the residual volume in the nebulizer, which tell us whether the technique is correct or incorrect. So yes, there are advancements not only in inhalers, but also in the nebulized world as well, because people have realized that this is an important delivery mechanism for patients who can't be maintained on inhalers. Uh, Dr. Vishakha, how do we maintain the nebulizer and the mask? How do we ensure that it stays clean, it stays apt, and the way we maintain our inhalers and our DPIs? How do we maintain the nebulizer and the mask?
So first of all, we have to explain the patient how to keep it. We should keep it in dry place. Don't keep it in damp place, because and after each use we have to clean the chamber, because deposition means drug remnants of drugs and all this thing will lead to chances of bacterial infection colonization. So we have to clean the chamber with clean water. We can daily after use we can clean the chamber with simple water and then let it dry. Tubing should not be cleaned. And every week we can, in India, we can tell them to boil for some 3 to 5 minutes, or we can use vinegar in 1:3 ratio for this disinfection, as at home the disinfectant agent might not be present. And patients should be, we should tell them that don't use same mask for if any other person in your home who is using a nebulizer. So mask should be different for all individuals who are using nebulizer at home. So all these instructions should be given to the patient, and we can tell them to change that mask and kit every 3 to 6 months when they are using it regularly. And in our practice, we are asking them to bring that mask in follow-up visit, so we can check directly whether it's clean or not. So these are the things we can guide to the patient for their benefit.
Very well said. Why not just have teach back approach for inhalers, but also for the nebulized mask to see whether the patient is doing it correctly and to see that the mask is clean at the end of a follow up. Probably that's correct, whether it's in person or over a phone call. Also, sometimes access to vinegar may not be possible. So a simple warm soapy water, the nebulized mask, the cups, that system can be just put in the warm soapy water, and the patients can just rinse it in the warm soapy water and running warm soapy water, and then just leave it out to dry. Cleaning becomes, sometimes patients tend to over clean the masks and the system. That's also something which we need to tell them, and ensuring that there's no humidity or the mask and the system is completely dry, because fungal spores and fungal colonization tends to thrive in a humid mask, and that's what we are worried about, and we don't want any of that to happen. So moving on to Dr. Saurabh, you've got a COPD patient who requires home nebulization. Two scenarios. Firstly, what would be your nebulized medication of choice in a COPD patient, in a group B COPD patient, or would you upfront put all the COPD patients on a triple combination therapy who require nebulization? So you've got a stable COPD patient who, for certain reasons, can't use inhaler, and you've got an unstable COPD patient.
Right. So, sir, this is a very interesting question as I was reading about it. So, the recommendation is to use a LABA and a LAMA combination. But in nebulization in India, we are rarely coming across a only LABA available. So, if we are ordering like formoterol, we always get a formoterol budesonide, be it Furacort, be it Pulmosmart, or be it other brand names. Unfortunately, when we are prescribing for the patients at home nebulization, we are prescribing them a LABA, LAMA, and ICS combination, which should not be what we should do. Ideally, the practice should be LABA and LAMA combination, and ICS for frequent exacerbators or who have a COPD A phenotype, or again we have high eosinophil predominance in their blood, which we have seen.
Okay, yes. So well said, but we, for COPD patients, we've typically had a SAPA-SAMA combination. We've been giving them to relieve their symptoms and elevate their symptoms. We do have a monotherapy with a LAMA, and we do have a monotherapy with a LABA as well. We've had arformoterol nebulization and glycopyrronium nebulization, both being there independently for a while now. And now we've got a combination of both the molecules together in the form of glycopyrronium and arformoterol being available to make it easy for our stable COPD patients who can't use the inhalers for cognitive issues, but require a nebulized medication. Even in the West, LAMA and arformoterol nebulization has been used. Unfortunately, remifenacin is not available in our country. But yes, for a stable COPD patients who do not require ICS, you do have the option of an arformoterol glycopyrronium nebulization, which can be given to them. And the off chance that you get a COPD group A patient who just requires a nebulized glycopyrronium or a arformoterol, that can also be considered. For your unstable COPD patients, yes, you could give them a nebulized LABA-LAMA combination as maintenance therapy, and probably a very low dose nebulized budesonide, which is available, or half the Respira, because the dose of the steroids in the COPD patients would not be that high. On similar context, moving to asthma, Akshay, uh, the same question to you in the form of an asthmatic patient. What would be your nebulized combination in asthmatics?
So important to note with asthma patients, what we do in our patients when we give them a PMDI as well as a DPI, the same thing applies for a patient with for nebulizer. So we use the same combinations. We're using a LABA ICS or we're using a SABA ICS. Important to note, we should always give an ICS to our patients with asthma and just not a SABA alone, because that has been recommended by the GINA guidelines recently. Important to also note that when we are giving patients nebulization for asthma, it's always a short-term therapy, most over a bridge therapy as such, and we'll try to shift them to shift them to inhalers when they're doing well. And important to note that there are some scenarios with asthma where we can also use them as maintenance. There is one scenario where suppose you have a patient with ABPA, with the current ABPA, so nebulized amphotericin B as per the Nebulam study can be given for a period of 6 months, which can increase the duration of increase the time to the first exaspiration. So there's a scenario where in asthma patients we can actually use nebulized amphotericin B as well. Otherwise, more or less, we're using a short-term duration for asthma patients.
Yes, but there's also a scenario of and subset of asthmatic patients who are geriatric, who are young, who can't be given inhalers and MDI with spaces. So in them, you would be giving a dose appropriate ICS formoterol combination as a twice a day therapy. So whether you've got a young person or an elderly person who does not require a high dose and just for maintenance it is required, probably a half Respiril twice a day would have an adequate effect similar to what you would be giving through an MDI with spacer. But yes, for your step 5 asthmatics or your step 4 moving towards step 5, then yes, the triple combination nebulization in the form of ICS LABA LAMA would be given to them. So yeah, so you do start with an ICS formoterol combination for your asthmatic nebulized patients. You gradually titrate the dose depending on the severity. But if you've got an exacerbation or if you've got your severe asthmatic patients, step 5 asthmatics, then an ICS LABA LAMA combination as maintenance nebulization would be the way to go. Okay, now Neel, now we've spoken about these nebulized combinations. What's your take on the combination, a dual combination and a triple combination nebulized form? You've got recently the ICS LABA LAMA also being in the nebulized form. What are your thoughts on this molecule and these combinations in nebulized forms?
So again, my word, because I heard Dr. Saurabh's just now, he just told that these are the options we have, so we have limited. So I would still feel that I agree with Dr. Avya here that our target should not be, or any treatment that we give should not be industry driven. It has to be patient driven. So whenever you have a patient that suppose has increased secretions, then you would, be it whatever your pathology, if it's COPD, is it asthma, then you would go as per your guidelines, but you would also go as per your patients. A lot of times, even there are a definite role of patients with triple therapy also. Suppose, like I said, the gold guidelines clearly tell us that for COPD patients with significant eosinophilia, with significant number of exacerbations, if there is a strong history of atopy and you feel sputum eosinophilia or blood eosinophilia is significant, in those patients, the inhaled steroid will definitely help you. So with your LABA LAMA ICS, that is probably a patient segment where the patient suppose is not able to use the inhaler properly, has dexterity problems, has cognitive impairment, you would use a triple combination nebulization at home. This is a very niche subsegment in your COPD patients. Same goes for patients with, so like I said, if there is a secretion problem, you use a LAMA, glycohale or glycopyrronium nebulizations are available. Similarly, for long-acting R-formoterol, Dr. Avya told us that it is available as a separate nebulization form where you have a specific requirement. Isolated ICS is also available as nebulization form. So based on your patient's profile, you decide the best for the either as a single combination or dual. The most studied dual combination therapy is salbutamol and ipratropium, which has been extensively studied probably because it was amongst the oldest. Now you have various combinations of formoterol, glycopyrronium, budesonide, a triple combination which is available. So, but you do go by your patient's requirements first, the guidelines after, and the industry comes last. So then that is how you would want to treat most of your patients when you decide on the long-term nebulization therapy for them.
Also, all the molecules work very well with each other. If you talk of the ICS LABA LAMA or the ICS SABA SAMA, they're all very stable, very potent with each other, and all of them can be mixed and used together.
And
Unfortunately, in our
only
country,
one glitch here when we are using ICS, we discussed fungal infections a lot. Now you will find that medico-legally also you're liable. So whenever you're prescribing a patient inhaled steroid in a patient with recurrent esophageal infections, pulmonary candida infections, fungal sepsis, on discharge, suppose you're prescribing a patient within 2 to 3 months comes back with a fungal infection. Then for you being a clinician or somebody who's attending this session, it is very vital that your rationale is very clear on why you are giving an inhaled steroid to the patient. If the patient has frequent fungal problems, has frequent pneumonias in general, exacerbations, then you should try a steroid sparing regime, because medico-legally also you need to be very clear on the drug which you are prescribing for patients.
I think the only nebulized combination which we don't have in our country currently is the formoterol revefenacin combination, which if we do get would be wonderful. Having said that, Dr. Shyamala, what are the maximum permissible doses of molecules while prescribed on home nebulization? We know the maximum permissible doses with respect to inhalers, MDIs, spacers, DPIs, but what about nebulized medication?
For the nebulized medication, especially the SAMAs, salbutamol, we can go up to 2.5 to 5 Yes, but in case of levosalbutamol, because we have availability of levosalbutamol, so the dosage requirement is very less. It can go from 0.31 to almost 1.25 mgs. And depending in case of an exacerbation, this can be used as an hourly, every 20 minutes for an hour to control it, and then later followed by every 4 to 6 hours in case of the levosalbutamol stabilization. And in case of venereal corticosteroid budesonide, the dosage can be escalated from 0.5 to 1 depending on the patient's monitoring status. In case patient not responding, it can escalate the dosage of same. We also have availability of the antimuscarinic agents, either some or the LAMAs. So where the dosage of the tiotropium can increase up to of 500.5 mg can be given. In case of glycopyrronium, 25 mcgs are used either once or twice a day in combination with the LABAs. And have the fluticasone also has been used as a inhaled form. 0.5 mg can be up to 0.5 mg can be used.
Yeah. So what we need to understand is that when we look at, let's break the three molecules. We've got a LABA, LAMA, and we've got an ICS. So when we speak of the ICS, typically budesonide becomes the most common nebulized ICS. So up to 2 milligrams is what we can give safely. That's what's recommended when we have a severe patient. We can go up to 2 milligram when we speak of formoterol nebulized form. So typically 48 mics becomes the upper limit, but in special situations when it's an exacerbation, a 72 mic upper limit has to be achieved. So when you combine it with your nebulized form, so maybe 3 respules or 3.5 respules in a bad situation can be considered. 50 mics of glycopyrronium is what we need to have an upper limit of. Now, also another thing which I'd like to tell our audience is that when we speak about SABA-SAMA combinations, when we have a pediatric population and if you're dealing with pediatric asthma, now you also have a combination of a low dose levosalbutamol that be kept in mind that you don't always need to have a SABA-SAMA full dose to be given to a pediatric or a subset population. You can have a low dose, typically where the dose of the ipratropium remains at 500 mics, but the dose of the bronchodilator, that's the SABA, comes down from 1.25 to 0.63. So there in the dose of levosalbutamol becomes 0.63 milligrams. So that's something called low dose, when in the pediatric population a low dose nebulized form can be considered. Dr. Vishakha, we often use mucolytics in our intensive care practice or in the OPD patients at home who have a lot of secretions, a bronchiectasis or a chronic bronchitis phenotype, or patients who just have a lot of phlegm which is being produced. Now, what are the specific set of instructions which we give these patients, and what are the dose of mucolytics and types of mucolytics which we use in a nebulized form?
So actually at home routinely we are not prescribing, but when patient is indoor, we are giving nebulized mucolytic like N-acetylcysteine and ambroxol, and we are giving first bronchodilator, and because as already discussed, this mucolytic agent can produce bronchospasm. So we first nebulize with bronchodilator, and then we give nebulized mucolytic agent, and then associated with chest physiotherapy. So chances of lung clearance will increase, and proper hydration of the patient should be maintained for proper clearance of the lung. So and if we have to give mucolytic at home, so it should be very cautiously given because it can produce bronchospasm. So we have to teach the patient that without forgetting taking bronchodilator first, and then they have to take this N-acetylcysteine or ambroxol after that. So it should be used cautiously in this patient.
Yes, because bronchospasm is something we're worried about. So typically when we use a mucolytic in the hospital setup for clearance of the airway or for sputum induction, we've got a 3%, 7% hypertonic saline which we can use, but bronchospasm is something we're worried about. So we've got data to say that probably N-acetylcysteine nebulization is much less of an irritant or less chances of bronchospasm being produced when we compare it to 7% saline with respect to N-acetylcysteine. So that's something which can be considered. Anywhere between 400 milligrams to 1 gram, 2 to 3 times a day can be the conventional dose, is what we use in N-acetylcysteine in the nebulized form. At home, although our back is against the wall, sometimes we don't have a choice but to use mucolytic nebulization at home when we have a bronchiectasis patients, when we have a COPD patients who produce a lot of sputum. But yes, it has to be coupled with physiotherapy, airway clearance techniques, and it has to be supervised. Now, moving from that question to Dr. Saurabh Ojha, now, if you don't have a choice and you have to use a mucolytic at home, what are the complications you are scared about, and how are you going to prevent them apart from the nebulization bronchodilators prior to that?
So one of the most important side effect or complication which I'm worried about is in itself bronchospasm, as discussed previously by Dr. Vishakha and Dr. Neel also. So the way to prevent it is pre-nebulization with a bronchodilator. Apart from that, the other challenges which we are facing is patients experience throat irritation a lot because of the odor. Patient develops intolerance or agitation because of the fishy odor of the particular compound. There is increased mucus. So sometimes that mucus can go and clog the jet system, and the mist and aerosol delivery gets disrupted. Very rarely, but it has been reported cases of hemoptysis, vomiting and diarrhea have also been seen in the patients. And yes.
Yeah, so very well said that we're worried about nausea. Typically, nausea because of the odor of the mucolytic agent. It's nauseous. It can produce a gag reflex. And also, we need to ensure that the minute we are giving a mucolytic nebulization, we've got someone for chest percussion, for airway clearance at that point of time, because sometimes the patients may not be able to expectorate or bring up the phlegm on their own. The mucolytic can break the disulfide bonds and make everything very thin and less viscous and less mucoid. But you need help and assistance in removing the entire mucus from the airways, whether you've got an assisted device, whether you've got an airway clearance device, or you've got a therapist standby. So these are the
Physiotherapist.
complications which we need to understand. And yes, hemoptysis at home can be a dreadful situation. Typically, it becomes tricky in bronchiectasis, whether the mucolytic itself is causing hemoptysis or the bronchiectasis has
Cough
worsened and it is causing
intensity.
hemoptysis. So that's something which becomes tough for us. Now, we've spoken about adults. Now, Akshay, how is nebulization in the pediatric population different from adults? Because we do see a lot of uh, pediatricians and even pediatric pulmonologists using it at home. So how is it different?
So when we come to the pediatric population, as we can see, the most important thing is the anatomy is itself different. So the pharynx is actually higher up, the epiglottis is floppy, the larynx is actually collapsible. So we have a collapsible airway which is in place, and with that we have if we have a crying child. So crying is actually a phenomena where there is a longer exhalation with a short inhalation. So this is actually very counterproductive to nebulizations. So these are challenges that you can face with when you're giving a nebulization to these patients. As you mentioned originally, that the dose that we give for nebulization for children is actually half. The GINA itself also has a separate dosage charge for children from 5 to 11 years of age, where the ICS dosage is actually half from that of adults. So we should always remember that the fixed dose should be lesser than actually 50% from what is given to the adults. Also, when the mask is actually placed for nebulization in children, the seal should be actually very tight because you have a small interface to take care. Even like there's a study which says that even if a 1 centimeter hole is actually gap is there, around 50% of the drug is actually lost. So these are some points that usually and challenges that we face with nebulization with pediatric population.
Yes. So first and foremost is the dose. Now you've got three subgroups. You've got an under 5, you've got a 6 to 11, and a 12 and above. So when we're typically talking about children and doses of the nebulized medication, we need to understand what's the age group, whether the child is 5 and below or 6 and above. So at that point of time, your maximum dose of ICS becomes a challenge. The dose of Sabasama or the dose of maybe a LABA above 6 years becomes questionable. Also, what we need to understand is that we can't prescribe LABAs below 6 years of age because of black box warning and no safety indication. So, which is why when you're prescribing a nebulized medication at home to the pediatric population below 6 years or an under 5, typically, as what the West would like to call it, it has to be an ICS plus a SABA. So that should be your dose given to these pediatric children. And also, you should be using a low dose SABA rather than a full dose SABA. When you move on to the 6 years and above, even then the dose of the ICS has to be at par with the age group. So, like Dr. Kawedia correctly said, if the dose of the inhaled corticosteroid 6 to 11 is half of that, what it is above 12. So, if you've got a max dose of 1600 mics of budesonide for an adult 12 and above, you've got a max dose of 800 up to 11 years of age. So that's something which we need to remember, that the dose of the inhaled corticosteroid And below 6 years, we typically do not use LAMA as a bronchodilator in the pediatric population, and we do not use a LAMA as well. So that's something which we need to remember and not get carried away. We've spoken a lot about drugs. We've spoken a lot about delivery devices, systems. What does the future hold for us, Neel? Any new advancements, new molecules which are going to be available in the nebulized form for respiratory physicians?
So the future, I think, will be number one molecules. I think one you said that we have got FDA approval for various molecules is again there are in ensifentrine, which is now FDA approved since June 2024. Hopefully will be available to us also soon, but that's used for maintenance for COPD patients as a PDE3 PDE4 inhibitor. There's also the drug which is revefenacin. So again, that's a once a day LAMA, again nebulization for home, which will be the future. It will, as a newer molecule, it will come. There are newer novel inhaled molecules also coming up. In India, particularly recently, we've seen we have various companies coming up with triple combination nebulizations, which are now available and which can be, like I said, selectively used as per your patient population. More importantly, we also have various delivery systems which are coming in that we also have various so there is the adaptive airway delivery systems where you have a nebulizer machines which can, so like we had auto CPAP machines with positive airway pressure devices. So nebulizer machine can detect your flow rate and accordingly deliver the flow rate with the adaptation of your airway and your inspiratory flow requirements. There are Bluetooth connected devices. There are devices which will have your dose tracking, which can give you auto feedback to what your inhalational errors are. It can be linked to your what is your peak inspiratory flow rate. Is it there will be digital integration with various applications with the particular device. So eventually you will have more of artificial intelligence enabled systems which will be coming up, and with these newer molecules probably help in proper adherence as well as integration with your clinical practice. But with better molecules, better combinations, better devices, you again, the most important will remain the clinician here who will decide which are the people necessary for these particular molecules or devices, and probably the compliance and the adherence will improve when we use specific proper nebulization therapy, especially combination molecules, and the newer agents which will come will be at very high costs initially. So once the patent breaks, that is when the cost will come down. But hopefully we'll have much more options to discuss in the future sessions when we have them actually.
Yeah, so the future is a twofold question: the future abroad and the future in India. And the future abroad has innovation and newer molecules, but the
So
molecules
you
available
will be
there.
able to tell us more from your European experience. That is what for
The
pulmonary
formateur.
artery hypertension. Do you have anything coming for nebulization?
So let's stick to first airway diseases. That's our topic. So hopefully we have formoterol revefenacin coming to India, but also there's going to be a lot of literature and studies being done on ensifentrine in combination with LAMA. So that's something which is going to happen in the next year or 2 years, where they use ensifentrine in COPD with combination of a LAMA, typically glycopyrrolium being the combination drug of choice. So that is something which is going to be new in the next 6 to 12 months, and hopefully we've got these molecules which come down. With respect to PH, we've got inhaled medication which is being available. But yeah, we've got the new kid on the block, Sotatus, which should be spoken about much more than inhaled medication in PH. I've had a fantastic brainstorming session with my panelists, and they've answered fantastically, and they've educated all of our logins. And we've got a mind blowing 1800 plus logins who stuck with us for the last 1.5 hours. And we've got over 100 questions in the chat box, which I hope to cover as many and have my panelists answer each and one of them. So without wasting further time, I'm going to move on to questions, and let's ask. Let's go in the reverse order. Neel, what are the signs of a nebulizer malfunction? So Dr. RG from Baroda is asking us from your place.
So what are the signs of nebulizer malfunction? So again,
Yes.
so number one, that if you notice that the chambers, that the mask with the chamber of the nebulization is always, so normally once you use the nebulizer, it should be, after you clean it, it should remain transparent. Now, if you feel that it is constantly misty, there is a lot of deposition of the particles over the mask and tubing. That means you have some tubing and mask which could eventually get secondary infection to yourself. So it can become a source. Second, the nebulizer, the machine itself. A lot of times you will find that there is a lot of noise coming in from the machine, but the mist is not coming. So you know that the nebulizer is malfunctioning because the compressor is working, but you're not able to get the appropriate drug delivery. A lot of times, especially with the conventional jet nebulizers, you find that there could be some electric malfunction also, that it can work for some time, it may not work at others. So you need to make sure that there is no electric problems accordingly. Sometimes with the portable machines. So I had a recent patient where, so now we have portable nebulizers are also coming up with a lot of companies like giving these nebulizers, as well as newer nebulizers which are Bluetooth, like you have battery backup for the nebulization. So we tried it for a patient like who was traveling, but then eventually you need to make sure that there is good battery backup, and these are all still in a very experimental phase, the ones which will run without electricity. So if there is any complication that a patient faces, you should always have a MDI with a spacer whenever you are using any form of portable nebulization, because if the device malfunctions and if the patient lands up with an exacerbation, especially in the air or when traveling, then you are at a problem. Or so you should, whenever you're using a portable nebulizer, you should make sure that you have a backup till we have more data and more battery backup for such devices. So these are some case scenarios which I can think of right now. If anybody from the panel
Also,
can add on.
yes, also what you need to remember is that very simple thing which you can observe a sign of malfunction is the noise. If the noise is suddenly higher than the baseline, then yes, it's not working properly on the residual volume of the drug. If you've got a very high residual volume of the drug, that means
Yeah,
the
it is not
nebulizer
completely utilized. It remains in the chamber.
precisely.
Yes.
Precisely. And always have a standby nebulizer at home in case the primary one gets spoiled. The whole purpose of you being on a nebulizer was because you can't take an inhaled medication in an MDA or a DPI form. So chances of you taking it again becomes less likely. So have a spare nebulizer like you've got your multiple inhalers and being an asthmatic. Dr. Vishakha, except bronchodilators, what other medications can be used in home nebulization? Dr. Sachin from Bombay is asking us this. Very quick
Yes,
answer so we can cover as many questions. Yes.
yes. Apart from bronchodilator, we can give mucolytics, as already discussed, like
Yeah.
NSAID, cysteine, and ambroxol, if needed with caution, and antibiotic like tobramycin for long-term in patients like bronchiectasis or cystic fibrosis. So these are the drugs commonly we are using.
And inhale corticosteroids and
Yes,
tobramycin nebulization. And
yes, yes.
hypertonic saline 3% and 7% as well can be used. Dr. Shyamala, can home nebulizations cause bronchospasm? Dr. Komal from Delhi is asking, apart from mucolytics.
Sir, if at all they're using some dilution, sometimes patients happen to dilute with water, and this can aggravate the bronchospasm, sir.
Okay, also what we need to remember is that even nebulized antibiotics, typically tobramycin nebulization and colistin nebulization, which we are giving to patients, can also trigger a reflex bronchospasm in these patients. And if the inhalation technique and the respiratory pattern is not good, then the drug is not going to have the desired effect, and the worsening of the baseline symptoms can be there.
So for patients with VAP, especially MDR, where we are using colistin at home or shifting out from the ICU and using in the room, we make sure that we use a salbutamol or a ipratropium salbutamol with the colistin prior to the colistin dose of the nebulization to prevent the colistin-induced bronchospasm, so that at least we can use that drug. Otherwise, if we use it alone, the patient will not use, and you'll end up stopping it. So that's protocol.
Correct.
Most of the ICUs now that they use that way.
Yeah, but that doesn't happen with every patient. So yes, you need to be mindful of bronchospasm, but don't use it as a blanket therapy. Dr. Saurabh is asking another question: is that can home nebulization reduce the need for oral bronchodilators such as theophylline?
Could you repeat the question?
Can you please repeat
Can
it?
home nebulization reduce the need for oral bronchodilators?
Definitely. So because that is one of the main advantages, that with inhalational therapy, the propensity of side effects of oral bronchodilators will reduce. So arrhythmias, tremors. So it will, but again, It may not necessarily in all cases, but in a lot of cases, we find the requirement of oral bronchodilators as well as the side effects will come down. So, and
The
even
drug
those may be
is
the cadre. So, if you find patients who are the oldest COPD patients, they will not want to stop Derriere. They will be addicted to that drug. So, in these cases, especially, you need to convince them if they are facing systemic side effects.
yeah. So, Dr. Saurabh, can you tell me how do we improve adherence to home nebulization? Dr. Arushi from Bombay is asking this.
So it is in order to improve the adherence, it is important that we, as mentioned, there is a physiotherapist. If we have mucus, then we can do. We are cleaning the devices properly. We are fitting the masks properly, and we are taking as advised the doses. We are checking our pulses. We are doing all the necessary, as I mentioned, observations and whatever findings which we are doing. I think that in itself is sufficient for improving the adherence.
Yes, so ensuring that the primary caregiver also works well with the patient to improve adherence, like we use in our chronic respiratory patients.
Then
Dr.
us, of
Akshay,
course, as clinicians, we have a very important role to
absolutely.
convince our patients.
Dr. Akshay, how often should the tubing system and the mask in the chamber be replaced? Dr. Aditya is asking us this question.
So, what the actually for each of these systems of nebulization, there's a different recommendation for the same. Usually, when we have these patients on home nebulization, the recommendation say the follow-up should be around 4 to 6 weeks. And changing of this mask, anything that is soiled needs to be changed. That's a but obvious question thing. But there is no such specific duration that at this duration you have to change it. It is something which is a manufacturer recommendation and different for different types of nebulizers.
Yes. So we need to see the maintenance and the cleanliness of the nebulized
Maintenance
mask
also.
and then take a call. Dr. Vishakha, Dr. Bhavna from Hyderabad asks us, can corticosteroids be mixed with other formulations not in fixed dose at home? Can we mix ICS with
Steroids
other molecules
with
as well?
ICS can
Yes.
be mixed with Sabasama, and routinely we are mixing it. And nowadays, Laba Lama ICS formulations are also available in combination, so we can add, but not with other antibiotic and mucolytic.
Perfect. So yes, you do have a Laba Lama combination or a Saba Sama combination, which can be used in an ICS combination. Dr. Shyamala,
Yes.
what precautions should healthcare providers advise nebulization in a crowded household? Dr. Suraj is asking us this question.
So usually that's very important, and because we always worry about the aerosolizations, and in case of patient who has secondary infections which can spread. So ideally, it is preferred to use it in a separate room, chamber, and preferably less number of people that are surrounding them will be better so choice.
So also what they can do is that ensure that the room is vacant where the patient is taking the
Exactly.
nebulization and ventilation is adequate. All the windows
Adequate.
are open. And for about 30 minutes to an hour after the
There should be
nebulized process
no
is
one
done,
should enter.
no one should be
Should be
entering. So
kept
these are
closed.
some
Kept closed.
precautions
And
which
the
can be
distance, the guidelines recommend 6 feet. So if it's a
6 feet.
crowded room, around 5 to 6 feet, that's the distance between, if at all you
Yes,
have.
correct. And ideally exit the room. That's the best way you can prevent yourself from being exposed to the aerosols which are generated. Now, Neel, can nebulization be used in tracheostomy patients? Dr. Suchi is asking us this.
We most of the ICUs we do use nebulizers, but again the caveat here is that if a patient has ARDS, if the patient has a lot of positive pressure requirement where de-recruitment is a problem and patient doesn't have significant bronchospasm. So in a lot of cases, it should not be that the patient's ventilation becomes your indication to nebulize. So there are so many patients who are tracheostomized who can remain without nebulization, but definitely for those with significant chronic airway disease, with significant bronchospasm, you have inline nebulization now. So with that inline nebulization, with the ventilation, you can easily nebulize these patients. But again, the indication has to be there because if at all patient has severe AR, even with the inline nebulization, there will be some degree of de-recruitment. So if the patient is very sick, has a lot of positive pressure requirement, and not very significant bronchospasm, then you should select patients accordingly. And definitely for VAPs, MDR VAPs, so when we use colistin, so there are studies which show that IV colistin, when combined with nebulized colistin, will have a better effect than IV colistin alone, especially when you are dealing with an MDR VAP. So say, and also for chronic Pseudomonas colonizers, where you feel that mucus plugging is there, then if you're using tobramycin, it will eventually help to bring your patient, wean them better. So all these cases, specific case scenarios where tracheostomized patient with will help with nebulization accordingly.
Also, what you need to understand is that does the patient have a chronic airway disease prior to being tracheostomized? That's the first important question. Every patient with a tracheostomy doesn't need to be on home nebulization round the clock. You've got a very important tool in your hand that's called a stethoscope. So auscultate the patient. If you're hearing conducted sounds, then you need mucolytics and bronchodilators. If the chest is clear, then you don't need any nebulization at all. Dr. Vishakha, can home nebulizations lead to infections? Dr. Chitra asks us.
Yes, home nebulization can lead to infection, as that's why we need to educate the patient regarding cleaning of the tubing and chamber of these instrument. So because the wet instrument leads to colonization of fungal and fungal spore and bacteria, so it may lead to infection. So we need to take
Yes.
proper care.
Dr. Saurabh, what all nebulized antibiotics are available? Dr. Chitra
So
is
as
asking us.
we have already discussed, inhaled tobramycin, inhaled colistin, even Dornase alpha for CFTR patients. These are some of the inhaled agents which are available readily in the market currently, and some which are being used quite extensively also.
Yeah,
Yes, inhaled
Spusinum also
tobramycin.
is being,
Yes, Astronam,
Spusinum,
correct. Yes, Astronam is also available. Inhaled gentamicin. We've got enough data where inhaled ciprofloxacin, fluoroquinolones are also being available abroad. You may have inhaled
For fungal,
itraconazole.
Amphotericin B is
yeah,
also
for
available,
fungal.
as
Yes,
Dr. Akshay has revealed.
yes. So in India, currently we've got inhaled tobramycin and inhaled colistin. Hopefully, we'll have official inhaled Astronam, inhaled itraconazole, and inhaled gentamicin available in the future, and inhaled ciprofloxacin. So let's hope, let's pray. Okay, Dr. Akshay, how can we minimize the risk of infections with nebulizers? Dr. Akash from Pune asks us this question.
So, minimizing risks is basically educating the patient is the most important thing here, that he needs to use the device and properly clean the device when it is soiled or after every use. This is one of the most important. Like if we go to ICUs also, we know that hand washing is the most important step. Similarly, washing the device that you're using is going to be the most important step to prevent any infections that could develop to patients on nebulization therapy.
Perfect. So washing it and maintaining it, that's the way to minimize the infection, and telling the patient to rinse their mouth and spit out, and
Yeah.
ensuring that it's a hygienic way of
I
using the nebulizer along with a primary care giver.
And I think
Dr.
using
Sam,
a checklist. So we have all these precautions. With your prescription, if you give them a checklist that this 1, 2, 3, 4, 5, 6, and that has to be a common thing that can help you in preventing infections and good care at home.
and also what you need to remember is that every time you need to have a teach back approach. The minute you have a teach back approach for your OPD, asthmatics, and COPD patients, the same needs to be done for your nebulized patients as well. That you can't take it for granted that they're doing everything correctly. You need to hammer it each and every time and be thorough with your
exactly.
questioning. Dr. Shyamala, you've got a patient on home nebulization, and how do we manage worsening of symptoms with patients on home nebulization? Dr. Sharwell is asking us this.
So against the monitoring, and the patient should be clearly warned and instructed whenever there's a worsening, they need to approach the healthcare facilities. So they can't just be continuing, because it happens that patient happens to keep on increasing the dosage and frequencies, and finally they just wait till the further worsening and then land up in the healthcare facilities.
Absolutely. Perfect answer. Call your healthcare practitioner. You're working on home nebulization. Please don't take it for granted. Call your healthcare practitioner. Very often, your healthcare practitioner would have given you an emergency action plan, whether it is an extra dose of the nebulized medication, whether it is oral therapy, XYZ would be written and given to you. But yes, please contact your healthcare practitioner. Neel, what's the dose of salbutamol in nebulization? Dr. Aryan is asking us this.
So salbutamol, like I said, it is not. It's going to be a short-term use nebulization only when you're using it. So never do you give it like a maintenance therapy. And if at all you're using salbutamol, you can use it in the form of only salbutamol or salbutamol and ipratropium. You use it with the respules, or you use it with the metered dose inhaler and the spacer. With regards to the respules, I think for salbutamol specifically, we have a single formulation only with the respules that are available with us. We don't have a low dose salbutamol separately. We do have, when we use a combination, as an example, ipratropium and salbutamol, we have low dose combinations available for patients who face problems of tachycardia, tremors, arrhythmias, such problems. In such cases, especially those who have cardiac problems, we come down on the dose of salbutamol so that we can still use the nebulizer with the lesser risk of cardiac arrhythmias. There are individual ipratropium nebulizations also which are available, individual glycopyrronium which are also available in such cases to prevent the side effects associated with salbutamol dosage.
Yeah, so what we need to remember is that you do have low dose levosalbutamol as monotherapy being available. So 0.63 milligram monotherapy of levosalbutamol is available, and the conventional dose becomes 1.25 milligram. Now that is available as monotherapy or in combination with an ipratropium. So you've got ipratropium, levosalbutamol, normal standard therapy 500 plus 1.25. You've got a low dose levosalbutamol 0.63 plus ipratropium 500, and you've got a low dose monotherapy of levosalbutamol at 0.63. Sometimes it's tough to find, but yes, it is available. So you've got all the settings and the dosage of levosalbutamol with or without ipratropium. Now, Dr. Santosh is asking us, Dr. Vishakha, that should home nebulization be considered in all patients with frequent exacerbations?
No, it's not like that. That in all patients we require home nebulization. We have to individualize the treatment, and we need to check compliance, their capability of taking inhalers, the proper technique, and all these things matter. So we need to individualize the therapy.
Yes, very rightly said. Home nebulization is not the solution. If a patient's not stable on inhaler therapy, you need to go your stepwise. If it's a COPD patient, your group E COPD, you need to consider add-on oral bronchodilators, add-on macrolide, add-on roflumilast, depending on the underlying etiology of the COPD. And when we speak and biologic injections, if you've got an eosinophil above 300, we've got mepolizumab being approved, and then consider an NIV support at home. Similarly, for asthma, you need to have a step 4 asthmatic when you're considering this, and then step 5 asthma therapy protocol, ruling out comorbidities, considering biologic injections, all of those things need to be understood. So nebulization is not a solution for a patient who's not controlled on inhalers. Dr. Saurabh, are home nebulizations prescribed to patients with a cough and cold rather than an airway disease?
No. At
Thank
the
you.
onset, I would say no. Please remember this. This is very, very important. So many of new physicians we see, our new residents, they just get a patient of cough and sir, we have too much cough, and they just upfront write nebulization. I would say no. As long as we are able to confirm it is an respiratory disease, obstructive airway disease, we should not advise nebulization to them. So we have too much wheezing, we have bronchospasm, we have those signs, then yes, it can be used initially for stabilizing the patient, but then we need to confirm it. We have spirometry, we have other tools, we have our own examination, clinical assessment. Only then should a practitioner be writing nebulization to such patients, not
Please
upfront.
remember, there is an upper respiratory tract and there is a lower respiratory tract. You do not need nebulization for an upper respiratory tract. Yes, sometimes you do give NS nebulization and budesonide nebulization for the vocal cord and the vocal cord involvement, but for cough and cold, it's not required. If you feel that the patient is having an upper airway issue, you've got nasal sprays, intranasal corticosteroid plus azelastine or whatever you may want to give as an antihistamine. Nasal spray is available. Nebulization is not the answer. Akshay, a very important question I'm going to ask you. Dr. Komal is asking us this: are home nebulization therapy and the home nebulization model, is it cost effective?
If you consider home nebulization not be is something, so see if a patient is having multiple exacerbation, ER resident hospitalizations. So if he's spending 5 days in the hospital every third month, and compared to that when he's using nebulizations as a maintenance therapy, obviously we'll notice that the nebulizations will actually turn out to be more cost effective than compared to frequent ER visits. And important to know that whenever you have an admission, your lung function doesn't come back to the baseline. It'll always drop further. And your patient will just keep on worsening if he's not actually controlled on symptoms. So in terms of patient symptoms as well as for cost, both of them, it is actually beneficial.
Yes, so that's one way to look at it. But also, what you need to remember is that if you have the potential of stepping down therapy from a nebulizer to an inhaler, that should be considered. Because when you compare the cost of nebulized medication with respect to inhaler, there is a stark difference. Let me phrase it to you. A single vial of an ICS LABA Respool is typically 50 rupees. You give it twice a day, it's 100 rupees per day. For a month, it becomes 3,000. You add a LAMA over that, that's again 40 rupees. So that's 80 per day, another 2,400. So typically the cost of home nebulizing a patient requiring ICS LABA LAMA twice a day therapy would be between 5,000 to 6,000 rupees. Your SIT therapy or your patients requiring MDI with spacer on triple therapy would cost anywhere between 500 to 1,500 depending on what type of Indian company molecule you're using. So yes, there is a stark difference when you look at the cost of therapy, but you need to look at the bigger picture. You can't be penny-wise smart and pound-wise foolish with respect to exacerbations and stepping down therapy. Okay, I've got time for one last question. I'm going to ask Dr. Shyamala. Ma'am, in the case of a post-operative setting when we've got comatose patients who are usually lying down, how do we use nebulization in these patients? Dr. Atharva is asking us this question. Since you've got the most experienced amongst all of us and you've taken active interest in critical care.
Post-op patients, definitely we can use it. But only thing it has to be monitored for, especially when we're using the inhaled corticosteroid, we had to monitor the secondary infections and the fungal infections. That has to be taken care, and it should not be a long-term continuation for these patients. Underlying parenchymal lesions has to be looked into, secondary infections. That will be the most common cause for especially patient coming with the patient presenting with the respiratory distress and things. Hence, it should not be a continuous long-term process.
Also, what you need to understand is the indication for prescribing a nebulization in a post-op comatose patient, whether this patient has a chronic respiratory disease. So the way and the technique of nebulization would remain the same. We are worried about aspiration, I'm assuming, in a post-op comatose patient. That needs to be managed with proper suctioning and keeping the patient proper after feeds. So the standard ICU would be the way it is. Yes. So I've got just enough time for one final take-home message from all my esteemed panelists. We're going to start with Dr. Saurabh.
Yes, sir. So, very important is we as clinicians need to be very sure of what we are writing, how we are writing, and to whom we are writing. This is my most important message. We need to be very careful of what particular nebulization we are choosing, what is the patient prodrome and what is the patient phenotype, or what is the patient symptoms, and only then we should start our nebulization, and obviously all else as we have said.
Dr. Akshay.
Home nebulization. So I'll keep it short. I'll just keep it that home nebulization should not always be used. It is an add-on, and inhalers are actually the first thing that you will actually use in most of our patients. In some subset of patients, which we described in the lecture earlier, is there where its use comes. Important to note that adherence as well as patient technique is still important in both scenarios.
Dr. Shyamala, madam.
Selection of the patients very important, sir, and instructions are to be clear enough to the patient for following and to have an adherence and good outcome of the nebulization therapy.
Dr. Vishakha.
Home nebulization should be individualized treatment in each and every case. It should be individualized.
Very well. So, Dr. Neel.
So I think we've had a very elaborate discussion. So it should be used not just because it's available, but because only cases where it is appropriate. We've discussed the entire list, but for COPD, poor dexterity, poor cognition, inability to and refractory disease, 3 indications. For asthma, pediatric, and in exacerbations, for bronchiectasis with frequent infections. This should be your take home for using maintenance home nebulization.
And my final take-home message for the audience would be that please don't forget a patient while on home nebulization. Just don't take it for granted that this is the way it's going to be for him or her for life. Always keep a mind out and always try and think of the possibility that yes, this probably may be a patient who may go back to his inhaler at some point of time, provided he or she can. So that's something which you need to remember. And like Dr. Vishakha very well said, is that personalized medicine is important. Each and every patient on home nebulization has to be treated differently. The requisitions and the requirements of the patient may be completely different from someone you've seen previously in your OPD or indoor. So with that thought, I'd like to thank all my esteemed panelists for this wonderful discussion and for answering all the questions multiple times of our audience. I like to thank all our participants and delegates and audience who've joined us, more than 1900 of them. Thank you so much for being so patient with us for the last 2 hours. And last and not the least, I'd like to thank the Indian Chess Society, Amita Madam and Dr. Chawla for organizing this wonderful webinar and having me learn so much from my esteemed speaker and panelists. Thank you, Lupin, for being so wonderful in coordinating and ensuring that we have a smooth webinar. And thank you so much. Looking forward to seeing you all and learning from you all soon. Thank you. Have a good
Thank you.
evening.
Thank
Thank
you.
you, Dr.
Thank
Avya,
you.
for your
Thank you.
excellent
Thank you.
moderation. I think
Yeah.
with the so many questions, we've had a huge fan following. We had so many people writing excellent moderation by Dr. Avya. So thank you so much for a very good moderation and discussion. Thank you to all the respected panelists. I got to learn a lot from all the panelists here. Thank you.
Thank you. Thank you, everyone. Thank you, Dr. Avya. Thank you, Dr. Neel. Thank you, panel.
Thank you. Can we go offline?
That was a wonderful discussion, sir. So, with your permission, can we close?
Yes. Thank you so much. Good night, everybody. Thank you so
Thank you.
much.
Good night.
Thank you.
Nice.
Good night.
Good night.
Good night, everyone. So, with that, we are closing this meeting.